Ron, thank you very much for the invitation to share our experiences in Seattle. Just as maybe a little brief history, the initial patient that came to Seattle was actually January 15th, of someone who had traveled to Wuhan, China, and came back quite sick. And at that point, he was admitted to one of our local hospitals, and they had been following the crisis pretty closely. So our public health officials were made aware of the potential for a challenge. I don't know if they anticipated a pandemic as early as January, and immediately the public health environment got started on thinking about how to manage the situation. Then there was a bit of a gap between that and testing and some nuances we could go into maybe on another type of discussion. But then in late February, we had that cohort in the nursing home that all got sick, and that was tragic. But in a way, it provided Seattle the opportunity to really understand the potential catastrophe that may occur, and because many of those patients were contained and many of them died. I think initially there were 32 that tested positive, and then ultimately over the time course about 41 had died in that environment. So we had two important things happen. Number one, it was a contained outbreak in a nursing home, and it was tragic because a lot died, and that really set the thermostat for us locally, in so much as that we recognized what could happen if vulnerable patients were exposed to this. And so the environment almost responded, which before even the governor's mandate for self-containment or to stay-at-home orders, that many of us were already respecting those types of issues. So we became very, very prepared very early. We were fortunate we had access reasonably early to testing. But we shut down from a cath lab perspective, we shut down all of our elective procedures down, or at least the majority of them. But we continued to have a very low cadence or a very low volume of patient activity, predominantly those that were inpatients or those who arrived at an emergency room. So that was really the beginning of the outbreak in Seattle. And we never really shut down the cath lab. We were never in a position where we had to flex our staff to other areas of the hospital. And we had reasonable access to testing fairly early.
So would you say that the tragic in the nursing home actually prompted the alert of everyone to start the social distancing early on? Because this was happened, I remember it was, I think, around the days of the CRT. We didn't pay much attention to that, but that was a very close, I think, end of February or very beginning of March that we heard about it. And is that fair to say?
We were very sensitized. So that nursing home is 1.5 miles from my house, and I was really concerned, obviously because of the high mortality. And I remember saying to my wife, I'm sure people are visiting those folks, and then they're having dinner on their way home, and we may ultimately be exposed, and we got very anxious, and we stopped eating out. I mean, simple things like that, and then little by little, people really understood the magnitude of the problem. But clearly, it was dramatic, and I would never say that there was a silver lining when something as tragic as this occurs. But I can say that it created enough of a certainty that there had to be a response, and we were able to calibrate that in so much as that we were able to respond to it, and ultimately, hopefully, we saved a lot of lives in this area.
Yeah, let me take an opportunity to welcome everybody to this. I appreciate all the introduction and sharing us your experience. And so this was Mark Reisman from Seattle. We have Cindy Grines. She's right now in Georgia. Lowell Satler here in Washington, 2 floors below me, and James Hermiller from Indianapolis. So welcome everybody. And if I can ask you one more question about when you came to a non-elective procedure, what did you do with the structural? You have a very robust structural program. How this was impacting that structural program in your institution?
Right. So from the very beginning, the patients who, even if they were asymptomatic and required a structural procedure, they were tested prior to arriving to the cath lab. So we maintained a testing profile on all the cases from as early as we can, you know, as the pandemic began.
But at that time, the testing took about 5 days until you get the answer. So what do? You test someone, you wait 5 days, and then you bring him to the lab? Or how this was actually worked practically?
Yeah, our earliest testing turnaround was within 72 hours. So basically what we would do is we would test, we would pause, and then we bring him to the lab.
So you continued to maintain the TAVR program, the LAA program closure?
No, so the TAVR program, we did a somewhat of a triage and a forecasting when looking at the patients. You know, obviously triage, you know, in terms of the severity or the need for the procedure, forecasting, you know, how to work patients up in a way that we were able to find if they needed to be treated, how to allocate the resources appropriately. And then we did what we call surveillance, where we kept an eye on the list that we had. But we were able to maintain a very low volume of TAVRs throughout the pandemic. And that was, you know, what we did was we only really chose the patients that had the minimal impact on our resources. So basically the patients that we chose were the ones that didn't require CCU, wouldn't require intubation, because at that point we didn't want to use N95s, even if we had a false, you know, negative or some issue like that. So we were really very careful to allocate the type of procedures which would impact minimally our system. In fact, you could almost consider it as if we had created a parallel care pathway in the hospital. We had a COVID positive pathway and a COVID negative pathway that we're running in parallel. And the COVID negative pathway was really predicated on the presence of a negative test.
Yeah, that's very important because we feel that a lot of patients are afraid to come to the hospital. Lol, you wanted to comment on that?
Absolutely.
Yeah, no, I'm interested in Mark's experience because that patient population that's not symptomatic is, or with COVID symptoms, I mean, they wouldn't let us test them here. We still can't. So of the patients that you were in the TAVR evaluation program, how many actually tested positive? Probably a very small number, if at all.
None of them tested positive, but
so you could even make a case for not doing it. I mean, as a benchmark to get into your system, right? I mean, they won't let us test asymptomatic patients here. So, and we wouldn't, I think in general, take a patient who had symptoms for a structural heart evaluation, but most of them don't. The biggest problem we're having is that they're afraid to come.
Right.
And so we had a run that we were finishing of about 3 weeks of patients in the system, but now it's sort of running dry because new ones don't want to come. And there's been no emphasis on establishing security or safety in the environment. It's just everyone's dealing with it, with the pandemic, and not looking at the other side of what we need to do to keep the hospital safe and be able to take care of not only structural but ACS patients. Because look at the volume of ACS; it's dropped by 40% everywhere.
Yeah, I'll make 2 comments if that's okay. So the first is that there was one of the index cases for us was a patient who was completely asymptomatic that needed a temporary pacemaker, and came to the lab completely asymptomatic and wound up testing positive. So that really got everybody anxious in the cath lab, obviously. The second comment I'll make is that I think our responsibility right now is that the traditional way of passively getting referrals is no longer acceptable because the patients are not going to their doctors, even their referral doctors. And I think we have to take some sort of active position in actually attempting to identify these patients and reaching out to our referrals. Because right now, what you and I and Jim and Cindy and Ron are used to, where we would just say, okay, when the referrals come, we'll treat. That is broken now. That's not occurring. And even we're a busy, like you guys, I don't know if we're busy as you are in terms of volume, but we really are not seeing a lot of patients even being referred anymore. It's not like we're holding them. People say, "Oh, as soon as this gets released, it's going to be like an explosion." I don't believe that's going to be
No,
the
they
case.
won't be.
Right.
Cindy, I want to talk to you a little bit about STEMI and how do you deal with that? Because again, what every lab still try to keep the STEMI patients. So if you get a call of a STEMI patient that is coming, do you evaluate whether he has a COVID positive, at least clinically? Obviously, we cannot do the test and keep the door to balloon time. Do you prefer to give them lytics if they have a compelling story that already have a COVID positive? I mean, what is your approach right now when you get a call for a STEMI patient to the lab?
Well, we just published just a few days ago, published online, and it will go into print, a joint agreement between SCI, ACC, and the American Society of Emergency Physicians. And we wrote this collaborative document that said STEMIs continue to go to the cath lab. Now, what's different about it is that they're stopping in the emergency room, even if they have a pre-hospital ECG showing ST elevation. They're not directly going to the cath lab. And the reason they're stopping in the emergency room is to do that further evaluation to see if they have symptoms. And also we're trying to do the rapid assay test. But I can tell you that at least with a rapid assay test and even with the older ones, there's a 30% false negative.
Mm-hmm.
And so we are in there, and we all know there's plenty of asymptomatic people out there. So what we're doing is if it's a confirmed COVID, we're taking the entire, the head and all of the gear and treating it like a confirmed COVID. Or if it's a patient under investigation, we'll do the same thing if they have symptoms. But in the absence of that, we're still treating them as a possible COVID, even with a negative test. And what we do is we put a mask on the patient. And by the way, our hospital is very proactive about this. Everybody who walks in that door has to wear a mask. Everybody gets their temperature taken. Nobody's allowed in there unless they're an employee or a patient. There's no visitors. So they've taken the opposite approach to what you're seeing, Lo. But be that as it may, once they come to the cath lab, then as we are all wearing I'm wearing an N95 for every single case. I'm wearing a splash guard, my normal lead glasses, double gloving, and double gowning. And of course, wearing the booties. And I think that with that approach, it seems to be relatively safe. In this document, what we're saying is that all those patients should go to the cath lab if it's a traditional STEMI. If you have questions, for example, if there's a diffuse ST elevation or the patient has very atypical symptoms, we're recommending a point of care ultrasound. And the reason for that is that there are cases of focal myocarditis that we're seeing with COVID, and perhaps if the regional wall motion abnormality, we can assume it's a STEMI that needs to go to the lab. But if there's no wall motion abnormality, perhaps you can monitor them. With regard to thrombolytics, we're not recommending that in anybody unless they are coming from an outside hospital where they're going to have a prolonged delay to get to the cath lab.
Yeah, it's interesting because we actually identify those patients sometimes clinically and also by their labs. I mean, some of those are troponin 100, 85. Usually they'll have normal corners, but I want to hear, Jim, your experience in Mid-America. I mean, are you much different than we do, or you're kind of the same?
Yeah, I think we're much the same. I think as far as where we are, about 2 weeks ago, we had about 100 plus on vents and maybe 250 in the house with COVID or PUI. And we're down to 40 on vents and maybe 100 in the hospital. So we're sort of on the down side of this as well. In terms of the structural, we really shut it down except for TAVR patients who were sick and had heart failure, or they really had critical AS. And, we probably do have 40 sitting in the wings right now that need to be done, and a bunch to be worked up because we canceled basically CTAs as well if the patients really weren't sick. And all the other structural, LA appendage, mitral clip, unless they're in the house really sick, that all got pushed aside as well. The STEMIs, like everyone, they've disappeared. They've come in occasionally. But our algorithm is much as Cindy outlined. The only thing we'll also do in the emergency room, which I really got this from Tim Henry, was do a quick portable X-ray in addition to the usual things. And we've picked up a couple patients who asymptomatic, afebrile, but their lungs, they've already got some early disease. And if the EKG isn't completely typical, get a point of care echo and try and decipher, is this just global hypokinesis or not? We're working on testing and having rapid testing, and we're not there yet with it. We're ramping up to start electives. We are going to try and do it not fast enough that too fast that we regret it, or too slow that we regret it. We're trying to really push virtual appointments with our patients. You know, we've got 100 cardiologists in the group, so we've got a large captured patient population, and we're trying to connect that way right now and restart the office.
Do you do any telemedicine or telehealth? I mean, is it really working for you guys?
It actually is working. The slope on that is like this, Ron. It's been sort of remarkable. I would say, in my patients, probably 60% it's video, audio, and the rest is just a phone call, but it keeps us in touch with those patients. And so we're trying to reach out, as everyone said, that part of the problem is they get lost. And so we're really pushing to continue to connect with them. And all of these structural patients, as well as ACS patients, we're trying to, particularly the ones that you're worried about, and that's pretty much all the TAVRs, is once a week calls to them to just make sure they're not getting sick and need to come in earlier.
Mm-hmm.
Yeah, the question would be how to bring those patients back. And again, I mean, I think the comments that has made here are important. It just maybe the telehealth, the only thing that, I mean, there are two views of that. I think Lowell view is that it's actually get them to less like to come to the hospital because they see an alternative that goes by the computer. Although not all the elderly really savvy about it. I'm not sure if you find them working. I mean, I tried to get my dad to get into Netflix from his iPad. It took me an hour and a half. And if it was not my dad, probably I wouldn't have done it. So I don't know what's your experience with this elderly population being.
You're absolutely right. They get over 75 and it's going to be a phone call because, you say FaceTime, they don't know what that is. Doxy.com, computer, internet they don't have. So the older they are, the less likely it's going to be a video and it's just an audio. But at least you keep in touch. I don't think they're going to love this virtual visit, and it's going to they're going to prefer that necessarily going forward. So we'll see. But yeah, it's worked for the group, and it's really ramped up relatively quickly.
What about reimbursement of those telehealth?
Yeah. So
I don't think it's good for new visits. We still rely very heavily on imaging, and if you get a new patient with AS, telehealth doesn't really help you, I don't think. I think it's good for the worried well and for the routine visits, a 30-day visit, a 1-year visit, a 3-month visit. But for a real evaluation, they still need to come down and get the studies that help us decide what we need to do next. So I think it's a new option, but it shouldn't be the primary option. It's just another option that we never had before. So I'm into all the telemedicine and teleradiology, but for new patient evaluations, they still need to come down to get the appropriate studies to make better decisions.
Yeah, I can't agree more. It's good for well baby visits, but if they're sick and new, we need to see them. In terms of the reimbursement, I think Ron asked about that. Really, if it's a tele and video, the reimbursement is equal to being in the office right now during the pandemic. We'll see what happens. For an audio visit, it's about 1/5 of that.
Oh,
So
wow.
Yeah, so it's worth to teach them to go. Do you have to document it on, do you have to record the visit? I mean, how do you capture if this was an audio or audio video?
Yeah, so right now we put it in the chart, but there's not sort of a link between whatever video mode we had and getting into the sort of computerized record. We just document that it was video or audio, and then there's a few other lines that you need to get reimbursed.
Mark, in Washington, you were the first state to have it, and probably, hopefully for you, the first state to get out of this. I mean, tell us what's the plans right now in Washington State. I know you have a very conservative governor that wants to keep you guys still in-house, and maybe he's rightfully doing it. But what's the notion there? I mean, you really have a month ahead of everybody on the game.
Yeah, sure. So as of next week, the clinics will be more active. We're going to obviously respect social distancing and all of the other nuances. In terms of elective procedures, starting mid-May, which is the 15th, and even before then, we've taken the approach that we would be doing those procedures if we believe that within a 3-month or 90-day period, the patient would be vulnerable to an adverse outcome. And that essentially, that basically is the majority of the patients that we see. So next week we have a couple of structural heart patients already pre-planned. We have 2 MitraClips on Monday. Both of those patients will be tested today, and we'll see them in the morning. They'll be dropped off by their significant other. We'll make sure that we have those test results before they actually arrive. And then we also obviously ask if there have been any change in, fever, chills, cough, or anything regarding, suspicion that something may have occurred in the intervening time period. And so that's the way we're proceeding at this point.
So the long-term plan or the short-term plan would be once you open in May 15, everybody who is going to an elective procedure will have to undergo a test prior to that to deem to be negative for COVID-19, or at least antibodies to show that he already had it, right? I mean, that's what.
Yeah, we're testing antibodies now, but I'm not sure, what to do with that particular piece of data. At least right, at this point in time. But yes, everybody will be tested.
Cindy, I have a question to you about your staff. I mean, kids are out of school, out of kindergarten, they're all at home. Do you feel short of staff or issues with staffing Cath lab if you ready to open that? Let's say your governor is probably the most aggressive in terms of opening, as you mentioned before, the tattoo parlors and others. So what's going to happen with staffing the Cath lab and all the ancillary help that you need?
Well, we're talking about doing elective cases starting next week, but we're going to ramp up first the ORs because there's a big backlog of oncology patients who need surgical procedures. And following that, our Cath lab is going to restart. I haven't really talked to the staff about what their needs are, but some of the hospitals I've heard are developing daycare centers for the staff, with all the schools being out. So we'll see how that goes. In our hospital, we haven't been requiring testing prior to procedures, but again, we are very cautious about every single patient has a mask, every single staff person has a mask, no matter what they're doing, except for eating, they have to be wearing their mask. And so we're trying to handle it that way. And again, one of the concerns that I have is the 30% false negative rate, because there's plenty of people who have a negative nasal swab, but maybe their eye is positive, or maybe their pulmonary lavage is positive for COVID. And so it's really hard to know what to make of, if it's a positive test, it's really helpful. If it's a negative test, I still don't know.
Lowell, what do you think going to be the biggest obstacle to bring things to some sense of normality and sufficient volume that can justify our work on a daily basis?
It's, I think, just safety. We really need to separate the COVID patients from the non-COVID patients, and to get the hospitals to have some sort of media blitz to ensure patient safety. That's the biggest problem I see, because they are afraid to come down. The ACS population, the structural population isn't as afraid. But what we tell them, it's really not going to be any different 3 months from now. You're going to have a background of COVID patients. And so waiting 3 months doesn't make a whole lot of sense. And as you say, Mark, they're going to get sick. That's predictable. So we've been trying to encourage them to come in. We don't force anyone to come in, but we've been trying to encourage. Everyone wants to work. The staff wants to work, even though they have problems at home. They don't want to be furloughed. They don't want to take PTO. The doctors are motivated to work. It's just getting the patients more comfortable in the safety of the system, that we have things in place. We're doing exactly what you're doing, Cindy. Everyone's wearing masks, their temperatures are taken. I'll tell you, the hardest part of the structural experience now is that there's no family. So they come in and they basically drop them off. And then, if everything goes well, it's very easy. But if there's a problem, the family can't come in and see them. The one thing about the structural side is we've had an accelerated program where we used to do, we do a Cath and a CT, and they go home and they come back in 2 weeks. Now we do everything as much as we can in one sitting. If they have AS, they get their Cath and their CT the next day, and then, we'll try to even do the TAVR the following day or the day after that. So the whole way we manage it is very streamlined.
Wow.
And like you said, Mark, we're looking at patients that are not too complicated, so that they're not in the hospital for any length.
And I think also, I don't know, I don't want to get too far ahead of ourselves, but there are a number of like really arcane rules that we've been following that really don't make sense. So for the patient that, for instance, needs a TAVR and a Watchman, and that's going to happen, we've had to do the TAVR, discharge them, bring them back. I think we have to talk to CMS about things like that, or people who get could get potentially a mitral clip and also require a TAVR. We discharge, bring them back because of some of the, sort of arcane billing, compromises that are involved in those decisions. So I would like that we put together some sort of position paper regarding that, where we could do what's best for the patient in the shortest amount of time and with the highest degree of safety for that individual.
Yeah, and CMS may be open. I mean, they cut a lot of red tape so far. I think that, again, campaigning to the patients is probably the most important part, because many patients are dying because they're not coming to the hospital, and they probably consider it to be COVID-19. Many patients come late. The number of CPRs are increasing because they're sitting under symptoms for 3-4 days. And the consequences of that would be much, much difficult than even getting a COVID-19 infected. So, but someone has to send that message, and we have to think about some campaigning or to our patients. I mean, you have to take care of yourself, and just hiding in the bunker or in the basement and waiting for things to come, it's not going to be the solution.
Yeah, I think, Ronnie, it would be great if the message about the number of people who are dying at home because they're too afraid to get to the hospital gets out to the lay public.
Mm-hmm.
I don't think they appreciate that at all, whether it's due to a STEMI they're ignoring at home, or they're just, they've got COVID and they come in way too late. So that message needs to get out there.
And it's not only cardiac patients, cancer patients, other, things that are being neglected now for the fear of COVID. And on the long run, I mean, because COVID is not going to be disappearing, I think that those who have in their hospital, like a hospital-free COVID versus hospital for COVID, I mean, we'll have to almost differentiate the hospital and to make closed centers that.
I think COVID testing and potentially, antibody testing may be as the equivalent of getting a Chem 7 when a patient arrives to the hospital. And also, we only have an N of 1, but brush up your skills on post-infarct VSD. We have a lovely lady who waited at home, and she got a big VSD, and she obviously didn't do very well. So this is a real issue, and it's something that's occurring right now.
So Cindy, I'll turn it up to you, because you are very active in SCI, and I know James Hermiller as well. But should the societies start to send that message to patients? I mean, don't sit on your symptoms, and find a way to come to the hospital to take care of yourself.
Well, I think they're trying to. There was a joint letter that was just published, I think 2 days ago, and it was all of the societies, including the Heart Rhythm Society, talking specifically about that, and also addressing the issue of stroke, because of course time is of the essence for stroke, for STEMI, and any number of things. But I think we really need to lobby the governments. I mean, when the governments have these stay-at-home orders and they threaten you $1,000 fine if you don't follow the orders, there's no qualifications for, you know, oh, but you should be cognizant of the fact that if you have symptoms, you need to come to the emergency room. And then the other thing is the press. The only thing the press talk about is how awful these emergency rooms are, how all of the staff are getting COVID-19 from working there. And you're seeing all these protests about lack of PPE. I mean, they need to say, give a positive message, or at least, you know, some sort of public alert.
Yeah.
Mm-hmm.
But it's
in addition to making it safe, I think we do have to have a slightly different business model. For example, Jim, you talk about outpatients. You know, you can't. I think that if you're developing a structure about resuming outpatient management, the traditional waiting room is probably gone.
Yeah. Yes.
And so some of the practices around here are setting up so that the patient waits in the parking lot in their car, and they keep them informed by phone or cell phone, and then someone comes out to the car and brings them in, you know, escorts them in to the, and actually in some way it's a little bit more personal, and they have the social distancing. So we have to have those structures in place to establish a safe environment. So it's not just saying you're safe, you have to actually do something besides separating some of the hospital patients. So we have to think about those types of important issues.
Right, those are good points.
Yeah, that's a great point. We just, you know, had a meeting this morning about that, Lowell, and that's exactly what we talked about. How are we going to keep them in the cars? Who's going to go out and sort of bring them in? Who is it that you're going to first bring in? Those are going to be the new patients, of course. And then we're going to open up an area that used to be an outpatient cath lab that's mothballed. And basically it's going to be a big waiting area that we can keep people apart.
Well, gentlemen and women and ladies, I mean, it really was interesting to hear the discussion. I think a lot of good points has been raised. So first and foremost, stay healthy and safe, and hope to see you all in person. There is a lot of challenges. We definitely in a different era now. We'll have to be creative, innovative, how to bring back the healthcare to our patients. So thanks everybody, and hopefully we'll see you soon in person.
Well, thanks for all you're doing, Ron, to make this, you know, for increasing the awareness.
Thank you, guys.
Yeah, Ron,
Okay.
thank you so much.